Thank you all very much for joining us for another episode of Scientifically Speaking. Today, we're going to be discussing actinic keratoses. There are some new developments and there's some new therapies, and we'll be discussing how these therapies work, what the clearance data shows, and how we use these in combination to make decisions for our patients. And we really have a world-class panel of experts. So with us is Dr. George Martin from Hawaii, Dr. Michael Gold from Nashville, Tennessee, and Dr. Neal Bhatia from Southern California. Gentlemen, tell us a little bit about something important to you in your hat. Neal, you go first.
Oh, you made Sam from San Diego today, but I'm always going to be from Wisconsin, just like Joel will be from Michigan. And I'm wearing this hat out of Rose Bowls gone by when we used to actually win by 20 points instead of losing by 1. So my heartbreak of Wisconsin teams being the bridesmaids is lost in this hat, which makes me the bride and the winner.
You know, Wisconsin is always a powerful force in hockey. Tony Granato, who's a friend of mine, is the head coach there. He just became in the Hockey Hall of Fame. And my hat is actually a tribute to the original 6 hockey teams that have played. I'm a big hockey fan. So Michael, tell us about your hat.
So I am also a huge hockey fan, having grown up in Philadelphia with the Broad Street Bullies and Bobby Clark and Bernie Parent and company, and winning all the Stanley Cups. That was great. And my hat is actually paying tribute to Dr. George Martin, who runs this most amazing meeting called Maui Derm. My wife and I have been fortunate to be going to Hawaii for over almost 30 years now. So, and this year we had to miss it because of COVID. We came on virtually and did everything we could to help virtually. I'm a big golfer. I love the Wailea courses. I love every golf course in Hawaii. And I miss George and Tony and everybody live, but hopefully, you know, next year I'll be wearing this hat on the Gold Course at Wailea.
I agree with you. Maui Derm is one of the most amazing academic meetings, and I've been fortunate to have been there for the past 14 or 15 years. Missed it this year, but it was fantastic virtually. And George, you put all this together. Tell us about your hat.
So I've got the Doc Martin sunscreen hat, and which I had to actually lose the name because of the shoe company. We're going to rebrand it Doc Hawaii, but it's really a legacy to living in Maui and the sun and such. And yeah, I miss Philadelphia and my Broad Street Bullies. I can barely spell the name hockey anymore, but you guys were missed. Neal Bhatia showed up in person with his bride at Maui Derm, rocked the house live, and we had about 20 faculty members. So we proved that you could have a meeting live in the face of COVID, and that's what we did.
Trip of the pandemic.
So we're talking hockey. So I'll show this. This is an
I love it.
This is from 19, God knows what, in the 70s, when the Philadelphia Flyers first won, and Kate Smith sang God Bless the Flyers, God Bless America every year, and Bernie Parent and Bobby Clark. So lots of fun memories.
You know, this is so nice. We always start off this way in Scientifically Speaking because you learn a lot about people that are your close friends. And, you know, hockey is very dear to me. My kids all know the original 6 hockey teams because Detroit is one of them, and Detroit is hockey town where I grew up. So we're going to be discussing actinic keratoses. And, you know, I really appreciate all of you joining us and Practical Dermatology and Modern Aesthetics for putting Scientifically Speaking together. This is really meant so that people in clinic seeing actinic keratoses patients every day can really understand the drugs that they're using, how these work, how to help our patients, what to expect from local skin reactions, and really how to think about the best treatment and combinations of treatments that we can offer. So I'm going to have George Martin start things out with really discussing the history of 5FU, how it works, and what it's actually doing.
So 5FU is our long, tried and true go-to topical field cancerization, field therapy for AKs. And it's had an evolution from the 5% 5FU, which really was came off of the internal chemotherapeutic drug, where it was recognized that the AKs started lighting up. And the evolution used to be, we used to have to treat our patients as residents back in the 80s for 4 to 6 weeks. And of course, nobody could tolerate that. And along comes the microsphere technology, where we were the 0.5% CARAC. And they did the pivotal studies of 1, 2, and 4 weeks. And what they showed was 1 week of therapy actually cleared about 70% of AKs. So what that means is you can get away with 1 week, clear 70% of AKs, and not basically make your patient look like they've been a house fire, should you treat them with 4 weeks of therapy. And of course, you might get a death threat. So, so the current deal with 5FU is you can treat short term for a week and get about 70% clearance. Or the latest rage is to mix equal parts with calcipotriene, which is also called calcipotriol. And if that confuses you, it's also called Dovanex, well known to us who treat psoriasis. And you can mix equal parts and apply it twice a day for 4 days. And what the addition of calcipotriene does is it increases the inflammatory response by regulating TSLP, which is produced by keratinocytes and recruits a bunch of inflammatory cytokines. And lo and behold, it really works. And it's a very robust response. And when compared to the regular 5FU, it totally outperforms it with 70, 80% clearances, face, scalp, arms, pretty impressive. So for those of you who want to put a little boost to your 5FU, throw in some Dovanex, put 50% quantities of both 5FU and Dovanex, put it on twice a day for 4 days, but be prepared for a very robust response.
It can be a brutal response.
Can we ask a question?
Yeah.
So Neal, in terms of the history of imiquimod, you and I were in residency 1999, 2000. Imiquimod came out, and trade name Aldera, Graceway, got it after 3M. But you and I went to some meetings for 3M. We talked about how best to use this in terms of AKs, superficial squamous cell, and squamous in situ. So talk us through the mechanism of action and the history of imiquimod.
Yeah, imiquimod is how Joel and I met back in 2001, which is definitely good history. But the concept of immune response modifiers was even before the idea of what it was going to treat. It was about boosting immune and innate responses that were already in motion, capitalizing on toll-like receptor technology of where can you optimize the antigenic response surveillance that's already put into place and what your immune system is not able to do. So all of these drugs came into market for warts. If you remember, external genital warts was the first indication for imiquimod based on 25 square centimeters. And I'll never forget Egbert Stockfeld saying, well, that's the size of everyone's genitals. So that's why it's 25 square centimeters. And kid you not, that's why the FDA actually uses 25 square centimeters in every clinical trial for measuring, a field of actinic keratosis, 4 to 8 in a 25 square centimeters from that paradigm. But then from there, the idea that you're taking the immune response, making it more productive, more aggressive, and more, efficient in recognizing keratinocyte dysplasia from warts, that translated to actinic keratosis. And then from there, it basically sped into the development of branded Aldara, which was 5% cream in the packets. That beget the kinder, gentler, if you will, concept of 3.75%, which is now Clyceri. And the idea too was compliance. Everyone was worried about packets. They didn't like individual meter size, and they wanted a pump. Instead, it actually came as a pump instead of a tube, which was probably a better delivery because you could still modulate how much you need for an individual dose. But long story short, is imiquimod is making your immune response work better, but the local skin reactions that are anticipated are all part of something that you have to counsel patients on because they are not desquamative. They are actually indurated and inflammatory without direct effect on the epidermis.
So the board question, toll-like receptors and then augmentation of alpha interferon. Can you speak to a little bit of the mechanism of action?
So by binding toll-like receptor 7 and partially 8, as opposed to resiquimod, which has a little bit more affinity to 8, there is a brisk processing of dendritic cell activity, which therefore translates into pro-inflammatory cytokines that are measured against the process. Interferons, tumor necrosis factor, TH1 driven cytokines, which will therefore augment the cellular response that's in motion. And that's what, again, creates the local skin reactions that are based on, fighting off that field of actinic damage and surveying for antigen, which is why we talk about what we see, but also what's on the way. And actually, one of the studies we did at our site was trying to predict visceral responses of who could get something similar to flu-like responses, because that's what one of the knocks was, who was going to get a systemic response from imiquimod. And we did a small pilot study that actually looked at the measurable interferons versus the comparison of local skin reactions and the clearance data, but also which age group and which surface areas. Because the nice thing about imicromod is you can still use it on the trunk and extremities, cover the face and scalp because of the indication, but that could lead to also the incidence of visceral responses that mimic the flu based on the effects of interferon, like you were just saying, Joel.
So, and then Michael, similar period of time, photodynamic therapy really gained some traction and popularity with Berlex and other pharma. You were there very early on as part of this. Talk us through PDT and the evolution of PDT.
So PDT, had its origins through, I'm going to mention names. Dr. Jeff Schulman, who was a dermatologist in Toronto, actually started the company that made the 20% 5-ALA solution. Worked with a gentleman named Stuart Marcus in developing this into what we call the Kerastick. So early on, I was involved in all the clinical trials. The concept is applying a photosynthesizer. So 20% ALA is a precursor and it gets into the skin, but it is selective only for actinically damaged skin or actinic keratoses. It can go into the sebaceous gland as well. And so that led to work to see about treating, at the beginning, individual lesions of actinic keratoses. And again, for lack of a better description, they picked 16 minutes and 40 seconds of light incubation after a overnight incubation period, because they felt that this conversion of the photosynthesizer into the active molecule that sort of gets taken by protoporphyrin IX with the light, that gives you the response, and you needed that kind of incubation. The problem with that, as everybody found out, is it hurt when you put the light on, and 16 hours and 40 seconds, which is 1,000 seconds, and there was no, at the beginning, any rationale behind that, that was what the FDA label became. And so over the next 10 years, we all worked at looking at different mechanisms, and I'm sure that George is going to share with us some new data. But I think in the interim, so we had 20% 5-ALA solution first, and I still use it as the Levulin Kerastick. But we really treat full face and scalp, so we treat arms and we treat chests and backs. The problem today is the expense. We also, at the same time that the Levulin product was being derived, there was a European product from Galderma called Medvix. Medvix had a wonderful clinical trial program. It's a methyl ALA, the methylated version of ALA, in a cream formulation, and it was used to treat actinic keratoses and superficial basal cells and superficial squamous cells. And again, the clinical trial program for that was extraordinary, using a red light source and with what they have. They actually tried to bring Medvix to the US several years back, and they tried to get an indication for basal cell carcinoma, not actinic keratoses, and it never took and it never progressed. So it was called Medvixia here in the US, and it just sort of went by the wayside. But we have a newer ALA product, which is the 10% gel. It's called Ameluz, made by Biofrontera, also in Europe, but also here, also with a red light. But the reality is, in today's world, the ALA, methyl ALA light absorption goes from the 400s up into the 600 range and so we have a variety of light sources that a lot of us have studied over the years. So we're able to use intense pulse light, we're able to use pulse dye laser, KTP lasers. And so we have a gamut of things, not only to treat AKs, but to rejuvenate the skin. And so the field has progressed, and as George will share later, now we have something called painless PDT. So that's good. And we also have daylight PDT. So the Europeans led that march, if you will. We don't need blue lights and red lights. You can just send the patient outside, even cloudy days, they've showed. And now in the US, there's a pretty big daylight PDT trial ongoing.
So we've seen some products come along and really not get tremendous traction in the marketplace. Diclofenac, which is Solaris, and other products. But we have a new product that just got FDA approved, Clyceri. I was an investigator, and George, you're an investigator. You're also an author on the New England Journal of Medicine article that just came out. So can you take us through Clyceri and the mechanism of action and the microtubules and really what's new with this?
Yeah, this is pretty exciting. Obviously, this is the first new drug to come along in a while. We've lost inguinal mebutate for a number of reasons, but this molecule is very specific. And what it does is it primarily inhibits alpha tubulin. And alpha tubulin makes up that spindle that's vitally important for setting up the spindle apparatus for the chromosomes to attach. And then when the cell divides, they separate. So once you destroy that, rapidly dividing cells die. Additionally, alpha tubulin is found in the cytoskeleton. It's also a railway upon which little micromolecules move along intracellularly. So you got 3 different points of attack. And so this molecule very specifically attacks rapidly dividing cells. It was developed by these really cool pathologists and scientists at Actinic who brought numerous oncologic molecules to being. They've licensed it to Amaral, and Amaral went and did the pivotal trial. And what they did was they well-powered with, a parallel trial, 57-day final reading, and they stratified about 350 patients to each arm. And the drug is applied, the 1% terbinabulin, which we now call Clyceri, is applied once a day for 5 days. And the take-home points are that at day 57, half the patients have 100% clearance. 3/4 of the patients have 75% clearance. And the number that all of us rely on heavily is the individual clearance rates were 87%. That's rock star. That's right up there above the 80% threshold. You need to be a player. What was interesting is the FDA said, that's great. Now, everybody who cleared 100% of their field, which was 25 square centimeters, what we want you to do is follow those patients along for a year and see who recurs. And what they found was this. They found that at the end of a year, roughly half the patients had a completely cleared field who basically remained clear from day 57 to a year out. And it's interesting, the FDA kind of lumps things together. They say, okay, well, any AK that pops up in the field at a year is a recurrent AK. Well, that's not necessarily true. Fortunately, they were able to map the original lesions and show that half the patients stayed clear and the other half had recurrences, 1 or 2 lesions pop up. So I think the biggest factor that's going to be a game changer on this one is that when they looked at the cumulative irritation score, like erythema, redness, scaling, crusting, erosions, ulcerations, and it was a 0 to 18 score, the average individual had like 3 to 4 on a scoring chart, which was basically some redness and scale. So I look at this saying, I haven't had my hands on it yet because it's coming out in April. I haven't had my hands on it to distribute to patients, but it's going to come out in a sachet. It's going to have 250 milligrams. It's really designed to treat 250 square centimeters, but like Aldera, we're going to have spread it over larger surface areas than that. What's important about this one is that we're going to have very minimal irritation. And so our patients will be able to go to work during treatment. I mean, think about a 5-day treatment, mild to modest irritation. Women can put makeup over it. Guys really don't care. And they'll be able to do the treatments without giving us pushback about these lengthy treatments, downtime, and things like that. So from an efficacy standpoint, it's a gain, it's outstanding. But more importantly, from an aesthetics standpoint and compliance standpoint, it's really going to be, I feel, very well received. So
George, you started to get into some of the benchmarks that we use when we evaluate all drugs. In terms of actinic keratoses, there's been an evolution historically from complete response or partial response and greater than 75% improvement to lesion response and then absolute recurrence rate over time. And you mentioned for specifically Clyceri, can you just walk us through the different parameters that are used? Because it's very difficult to make apples to apples comparisons because these drugs were approved at different times. And after approval, we were not really seeing head-to-head trials. So how to really make sense out of all this?
Yeah, so the FDA requirement is 75% and 100% field clearance. That in itself is problematic because Clyceri modeled itself after Takeda, which was a 25 square centimeter treatment area. When you look at other trials like PDT, the trials that Michael did, they were kind of lesion directed. They weren't areas, they were lesion directed. When we look at Clyceri, for example, the 2.5 and 3.75% Clyceri, the imiquimod, that was full face, full scalp. So there's your apples to apples, oranges to oranges, 3/4 and 100% clearance. What we really rely on, and the optimal comparator is individual lesion clearance. In other words, we want a median number of individual lesions cleared from a field. And sort of the benchmark is if you're above 80%, you're in play. Those other 20% are really, really hard to clear, and there's numerous reasons for that. So, just to be understood, now the FDA is like wanting to look at long-term clearance. If you have a field that's cleared 100%, are they going to stay clear at a year? And now what we're also seeing, Joel, and this is very interesting, is that, and Clyceri is being held to this, they're looking at 3-year data. In other words, you treat over the course of 3 years, and you measure fields for the development of non-melanoma skin cancer. So think about this. We treat fields to decrease AKs with the presumption that we're going to decrease the number of non-melanoma skin cancers, basal cells and squamous cell. But yet, if you look at it, have we really proven we've done so? Yes, in 1 year ALA trials and a few things. But now the FDA is saying, hey, look, we want these 3-year trials where you use your drug and prove to us at the end of 3 years that you have reduced the incidence of non-melanoma skin cancer, or have at least a reduction compared to what the current benchmarks are, which is about a 3% development of non-melanoma skin cancer over a 3-year period in a treatment field that's about 50 square centimeters. That's what got Neal Bhatia into trouble, because their numbers were higher than imiquimod, and although comparable to diclofenac. And imiquimod is still over 3 years the benchmark for reducing the incidence of non-melanoma skin cancer, anywhere from a half to a third of what diclofenac and Neal Bhatia were able to do. So in a long, windy discourse on this, in summary, I use the median individual AK clearance as a benchmark. You got to be over 80%. And now that the new trials are coming out, looking at these field therapies and reducing the incidence of non-melanoma skin cancer, look for some comparator long-term trials. And I know Clyceri is in it, and it's going, I believe, head-to-head with diclofenac.
Thanks, George. In terms of, Michael, you wrote several years ago in Journal of Drugs and Dermatology a pharmacoeconomic analysis where you actually juxtaposed the different medications and talked about how it's used and cost. And really overall parameters and benchmarks was really a holdup, because all these studies were done differently. You had different clearance rates depending on what the endpoint was. I really want to hone in on local skin reactions. I think that this is where Clyceri really makes a potential difference. Having participated in the trial, I agree with you, George. Many patients really had very little irritation or local skin reaction or erythema at all, allowing them to work. And we're at a point where many people who are combining 5-FU and vitamin D are really causing a brutal inflammatory reaction. I see many patients who actually come in treated by one of my colleagues or in other facilities where sometimes people actually can't even have their COVID mask in contact with their skin because it's tough. And, even though these have been done on sequential days, I wonder if there's something that we can do where we space this out over a longer period of time so it's not as robust. And as a Mohs surgeon, I don't want my patients coming in with that type of robust areas of irritation and erythema, because clinically, that's what's going on. Histologically, we see a lot of inflammation, and I don't want to see that when I'm doing Mohs. So, Michael, talk to us a little bit about ways that you can actually decrease some of the inflammatory response, whether it's 5-FU, whether it's imiquimod, whether it's PDT, ways that we can actually get our patients through these treatments and still have efficacy.
Well, I don't know if there's a lot of ways without, again, I don't think anybody, and you guys would know more than me, of reducing the inflammatory response, which is what you need to clear the AKs. That's why we're doing it. When we used to do PDT at the beginning for such a long amount of incubation and light, I mean, we got people redder than my cap, and they looked like Wisconsin caps. These people, but we needed that inflammatory response. And so that's always been the limiting factor. And I think that, one of the things that I see in my practice, and you may see in your practice, people get the 5-FU treatments, but they're given a topical steroid with that. And again, does that decrease the efficacy? And I think that, one of the big things with the inguinal mutated drug is we didn't know all the cosmetic adverse events of this drug at what, you know, that sort of came out afterwards with pigmentation problems and so forth. And that sort of, to me, was one of its biggest downfalls as a topical therapy. Clyceri seems not to have this, and seems that during the trials, this was a very big part of the, you know, looking at what happened after this, after the application. If that's the case, you know, and again, it seems very well tolerated, that's nice. I think I'm not the biggest 5-FU user because I don't think my patients tolerate it, and I don't think they listen to what I say as far as, you know, how you need the inflammatory response. And again, I think it's, I think we as dermatologists have said, okay, use some of this steroid or use some of this, not like George is saying, where you want that calcipotriol boost. I mean, that's what you need. So I think that PDT has a wonderful place with a shorter drug incubation, no matter if it's the Levulan or the Amulus that we have available. And we keep the light treatments down. We're still seeing, you know, really nice clearances when we do that. You know, and again, I think in my world, I'm going to use Clyceri as sort of the, you know, part of my treatment plans with my PDT treatments. I think together it's going to be a great therapy. And I think, and you mentioned you mentioned also about the pharmacoeconomics thing that I did like 100 years ago. You know, that's an important thing, you know, for doctors to realize, because you get reimbursement. At least we used to get pretty good reimbursement for doing these procedures in our offices versus just writing a prescription. And, you know, there's something to be said for both sides of the argument. And so you have to, you know, you out there have to make that call. But I think that I'm a procedure guy as you're a Mohs surgeon. I mean, I like doing procedures. And so I want to be able to treat my patients, but you also want to make sure that you're giving them the best alternatives. And I agree with what George said. This could be a game changer for us.
So in terms of really understanding downtime, we know that whether you're using 5-FU, whether you're using imiquimod or doing PDT, you come to expect that there is going to be some reactivity in the skin. And we all want to make this more bearable for our patients. And Neal, you've been involved from the very beginning, looking at, you know, first of all, Stu Stalachet's studies with imiquimod, where he did cycle therapy, 2 weeks on, 2 weeks off. You know, we've all kind of evolved where we do some of that. We can do a week on, week off, and 4 cycles. But traditionally, you know, it's about 30 days of application. So talk to us about how you really use these modalities where you can get people comfortable, even if they're having irritation, you sort of take a break or you take a little drug holiday and then you restart it.
Yeah, I mean, the key to the tolerability equation is to understand MOA first. And to build on George's story about terbinafulin is the difference between induction of apoptosis versus necrosis. You know, 5-FU and indolent mediated worked via necrosis pathways, which is why you saw those brisk local skin reactions. And like with indolent mediated, once you started the course, the horse was out of the barn. And, you know, using steroids, you know, like Michael just said, it's not going to give you what you want out of the efficacy. And so there are a lot of things that we can do, like hypochlorous acid and topical anesthetics, antihistamines for PDT, a lot of different things to reduce some of the cellular responses that induce pain and itch and edema, and still keep the efficacy of therapies going. And, you know, to your point about imiquimod, we used to rotate on and off to find the right regimen, which is what basically was the genesis of Clyceri, was that Stalachet method of couple weeks on, couple weeks on, off for a 3-month recipe. That's what led to 2 weeks on, 2 weeks off for that recipe. And they actually did that in the trials, looking at different weeks and different percentages. I think the point of the equation for patients, you know, they are anticipating erythema, they're anticipating, you know, desquamation for some therapies, but what we're seeing with terbinafulin is, you know, there's erythema and flaking because of the localized impact on actinic keratoses, but there's not the desquamative effect that you see vesiculation and crusting and deep, you know, slough like you would with 5-FU and indolent mediated, again, because if you understand MOA, you understand where necrosis versus apoptosis fits. I think to the other thing that both of you said if you go back to, the guy wearing the mask, the guy who's on a camera, Joel, you have a lot of people on TV as your patients, for example, all of these people who are worried about their appearance, you have to remind them that all of those years in the sun didn't happen, overnight. And that's why the radar of some of these treatments is getting not what's coming, not what they see, but what's coming. And that's the difference between making things go away and making things stay away. So a lot of that context has to be put into patients. But the number one thing I always tell everybody when we're talking about this is avoid the word side effects when you're talking about these local skin reactions. These are anticipated local skin reactions that will happen from their mechanism. And
I think that's really important. That's really important. You have to, I think that having that discussion with the patient, no matter what we do, having that.
You hit on a good point before, which I forgot. You remember 14 hours of incubation of blue light. That was the origin of daylight PDT. We used to incubate people, send them home. The minute they opened the garage door in the morning, boom, they got incubated.
Correct.
Right?
Correct.
And that was what started the whole process. So we have to be able to mitigate that.
You indicated really understanding mechanism of action is really critical, and the whole concept of topical steroids may shut some things down. From a photodynamic therapy perspective, there's been a lot of emphasis placed on really trying to make this a more tolerable treatment for people because it's done in the office. Many patients really prefer that. You don't have to go home, give them a script and give them homework to apply something that's uncomfortable and unsightly. So many people really appreciate the fact that we do a lot of PDT in our office, and we want to make this a more comfortable experience for them. So little things can actually be done. There was an article by Brooke in Journal of Investigative Dermatology about giving patients antihistamines before the procedure. So you cut down on the inflammatory response, from swelling perspective, but you don't actually inhibit the overall efficacy. And George Martin has really dedicated many years to trying to figure out a better way to do PDT where people can do PDT where there's less of an irritation and there's less of a time period in the office and overall less overall downtime. So George, take us through really how you came up with this Martinizing 1 hour procedure and where people have gone with that from there.
Okay. So if you really look at the original studies on PDT, it hurt, particularly when you do an overnight incubation. It hurts like heck. And then as they moved to 1, 2, and 3 hour incubation with the original phase 2, and then of course phase 3 study, half the patients had moderate to severe pain. So again, hurts like hell. And when you have cowboys white knuckle it, like we have Paniolo guys white knuckle it here on Maui, it hurts like hell. So how could you figure this out? So it really started back in 2011 when the European PDT group came across the idea of doing daylight mediated PDT. And here was the concept. First of all, they wanted patients outside the waiting room. They didn't want patients sitting around occupying their waiting rooms. So they had to figure out a way to lessen the patient's presence in the waiting rooms and then staff time. That was number one. So they figured, hey, visible light outdoors is a perfect illumination source. The second thing is that they applied the methyl ALA for 1.5 and 2.5 hours and incubation time. And the way it worked was they took the patient, they put the methyl ALA on, they let it sit 30 minutes, and then they had them go outside, walk around the parking lot for 1.5 hours or 2.5 hours. Lo and behold, they got 75% clearance, and on the pain scores, significant pain was less than 10% of patients. It's like, oh my gosh, well, why could that happen? So the concept is basically this. From the time you put on a prodrug like methyl ALA or ALA on the skin, it starts getting converted into the photosensitizer we know as protoporphyrin IX. That's what blows up cells. The problem is probably after 10 or 15 minutes, that protoporphyrin IX inside the cell starts to leak out and cause collateral damage. And particularly when that protoporphyrin IX is illuminated, it probably lights up the nerves and blows up the nerves, the cutaneous nerves. That's why you get so much pain. So the goal was to shorten the incubation time before you turned on the light. So their concept was it was a half hour before they had them walk out in the sunlight, virtually no pain. But as we know, you start having patients walking around outside and they forget, they start talking to friends, you can get into trouble. And you know how lawyers circle like vultures, right? Or the other problem is weather. Try doing outdoor daylight mediated PDT in Minnesota in January or in Florida during the summer when it's raining. Forget it. So I just simply took their concept, moved it indoors into the office. We put the Levulan on, and then 15 minutes later, we put the lights on, and patients had no pain, and half the AKs were destroyed. So, and again, zero pain, and half of the AKs were destroyed, consistent with, in our split face study, the standard 1 hour incubation, turn on the light for 1,000 seconds. Now,
Are you treating individual lesions, George?
full area, full face, right?
Yeah.
And the comparator study, I painted half the face with Levulan, 15 minutes later, turned on the blue light. And then when I was done, the other side was marinating with the Levulan for an hour and 15 minutes. Then I put the light on the other side, and lo and behold, got the same clearance rates, roughly 50%. And we know that with the DUSA study, 1, 2, and 3 hour incubation, you got about 50% clearance after one treatment. So our study was certainly consistent with it. The difference is when you incubate for 15 minutes and then turn the light on for an hour, you had no pain. So taking this a step further, Ed Nathan and I, and Ed's at the Cleveland Clinic, have been discussing for years, really refining how long should we incubate, how long should we turn on the light. And so what Ed did, and it's recently published this past year in the JAD, is that he did a split face study, face and scalp. And what he did was, on one side, he did the standard 1 hour incubation, right? And 1,000 seconds of blue light. On the other side, he randomized it to simultaneous application and illumination for 30, 45, and 60 minutes. Basically, paint the Levulan on, and you turn the light on for either 35 or 30, 45, or 60 minutes. And the results were equivalent, that the standard protocol and the simultaneous incubation and illumination had exactly the same outcome. The difference was in the pain scores, that when you paint the Levulan on and turn on the light right away for 30 minutes, zero pain, like almost zero pain. So what he did was he said, you know what? 30 minutes worked as well as 45-minute incubation and 60-minute incubation and simultaneous illumination. He took 100 patients, painted them with Levulan full face, turned on the light right away for 30 minutes, turned it off, done. So what are we doing now? Simultaneous 30-minute incubation and illumination. In other words, the moment you put on the ALA, and by the way, you could use the 10% Ameluz gel interchangeably with the Levulan. Just slurp it on, make sure, the patient's tucked away, and then immediately turn on the light for 30 minutes. The little red thermometer pops out of the turkey, you're done. The key thing is no pain.